Whatever the initial lesion, and we have seen that these lesions can be combined, our final and ideal objective is immediate mobilization. This immediate mobilization is associated with passive mobilization. In our opinion, passive mobilization is preferably achieved using mechanotherapy apparatus, which allows the period of mobilization in the day to be extended according to our protocols. The value of early mobilization is to regain immediately the gliding surfaces. For example, this lady underwent tendolysis of the flexor tendons, i.e. secondary surgical release. She was mobilized straight away, both passively and actively, and the result after 8 days is already rather encouraging. Passive and manual mobilization will be followed up by mobilization by mechanotherapy. This will enable us to increase the gliding surfaces and make sure that the fingers can be completely flexed. Continuous passive mobilization for several weeks allows us to obtain a complete result, as for example in this patient who underwent the same intervention a month ago for the same condition. Here is an example of immediate post-operative mobilization. The protocol was devised with the surgeon's agreement. This patient underwent a ligamental plasty operation yesterday in the wrist. Immediate passive mobilization starts the day after the operation. We set the possible mobilities depending on what the surgeon has given and depending on how robust the structure is. Most of the surgical techniques used nowadays allow immediate mobilization, apart from perhaps certain techniques used in prosthetic surgery or due to capsular healing. It is sometimes necessary to immobilize the hand temporarily or to delay passive mobilization using mechanotherapy until later. The implementation of certain protocols in specialist units interests us, but can also be applied in GP surgeries with a program devised beforehand. Continuous passive mobilization is an important element in the management of the rehabilitation of patients with degenerative disease of the wrist and fingers. Here is an example of a hand with rheumatoid arthritis in which the wrist and metacarpophalangeal joints are affected. In this example, it was treated by total arthrodesis of the wrist and arthroplasty using metacarpal implants. In this patient, who presented with trauma to the first web, which led to cutaneous destruction, a skin graft was applied. We know that in skin grafts, the thinner they are, the more chance they stand of taking, but the more tendency they have to shrink. Conversely, the thicker the skin grafts are, the more chance they have of taking and the more flexible they are. The skin graft lies right on the web, so retraction will lead to progressive closure of the web, resulting in impairment to opposition of the thumb, which is extremely detrimental to function. As soon as one is certain that the skin graft has started to take, i.e. during the first few days, active and passive mobilization must be encouraged, involving opening the web and working on thumb opposition to avoid closure of the web.